Hello everyone, my name is Emily Kosick and I'm the Knowledge Manager for the Canadian Institute for Public Safety Research and Treatment. Welcome to today's session, Occupational, Personal and Psychological Impact of COVID-19 during Changing Pandemic Health Order Restrictions. Long title today. Before we get started today, there are a few housekeeping items that I do want to go through. All attendees are in listen-only mode. This is to limit feedback and noise during the presentation. Today's session is also being recorded. You'll be sent a copy tomorrow automatically, so if you miss anything, you can go ahead and you can watch it again. Just so you know, the GoToWebinar launch window can be blocked by some organizations. So if you're having trouble hearing or seeing, you may have to join us by phone. Lastly, we will be looking for questions from the audience at the end of the session, so please send us your questions through the questions box or be ready to raise your hand to ask your question live. Now, I'm pleased to introduce our speakers for today. First, Dr. Gregory Anderson, Dean of the Faculty of Science at Thompson Rivers University. You can go ahead and wave there, Greg. And then we also have Captain Steve Farina from Coquitlam Fire Rescue, who is also the Vice President of the Lower Mainland for the Professional Firefighters Association. So Greg, I'm going to go ahead and change presenter control to you. So you have it.
You can tell me.
It's displayed just fine, so I will pop off.
Perfect. Well, thank you very much and welcome. We're very happy to be able to present to you today on some work that we've been doing in British Columbia around responses to COVID-19 and the impact that they've had on the mental health of public safety professionals. I did want to acknowledge a couple people first. Some of the work has been funded by my CIHR grants. Some have been funded by Dr. Carlton's CIHR grants. And we also have Dr. Heidi Cram and Dr. Diane Grohl, who were working on this project with me. So there's quite a few people involved, and I just wanted to make sure that everybody was acknowledged. What we were really trying to do today was talk about the impact of COVID-19 on the mental health and well-being of firefighters, paramedic, and public safety communicators. That's what the data we have. And really talk about what happened during the different phases of public health order response. And in BC, that was at the beginning, wear a mask, stay 2 meters apart. It went into restricted dining and size of public venues, meetings, that type of thing. It started to get more restrictive in our third phase, where alcohol couldn't be sold after 10 o'clock in the evening or 10:30. Sizes of gatherings were down to 10. Started to get much more restrictive, and then finally in phase 4, everything was locked down, everything was closed except essential services, and we had travel restrictions where you couldn't travel between health regions. So we had this escalation of response, and obviously all of our public safety professionals were working through all of that as we watched the rest of the province slowly shut down and now come back into working again and trying to move forward. So I wanted to start the day with a really big quote. I apologize. I'm going to take time to read it though, because it does set the context for where we're going to go. A little bit of context at the beginning, show you some data, and then have some discussion. At the end, we're really going to just really talk about the so what and share some lived experience of public safety professionals in British Columbia. So here's the big quote. Compared to the adrenaline-fueled response in the spring and the false dawn about the recovery over the summer, the second wave requires a new understanding of personal resilience. In the first wave, personal resilience relied on the psychological emergency response called arousal. Shocks, threats, and sudden uncertainty make us super alert, and we activate resources that are skin deep. Adrenaline, fighting spirit, and pulling together. This response is impulsive. almost universal, and immediately recognizable across many teams. Personal resilience in the second wave is a different story because it relies on psychological stamina, which rests on more deep-seated emotional patterns shaped by our individual needs, histories, and experiences. Stamina is required because the second wave is not exciting at all. People report feeling bored, disconnected, and unnerved. In contrast to the skin-deep reaction to the first wave, the second wave requires perseverance, endurance, and even defiance against the randomness, gloom, and burden of the pandemic. Cultivating resilience requires some emotional rewiring and calls for a different kind of appeal to team members and colleagues. The essential task is to identify your biggest challenges over the next year and then tap the psychological stamina you and your team need to get there. And there are three sort of key things to that: understanding the difference between urgency and importance, balancing comfort and containment, and finding new ways to energize yourself and others. So this was published in the Harvard Business Review, and I thought it really captured the essence of how people responded to the pandemic. And I'm going to show you data that sort of follows through with this and shows you some of that response. Steve?
Right on, Greg. Yeah, that's a very powerful quote. And actually, as you're reading through that, it's like, yep, that's exactly how I felt. And leading up to that it's interesting because the opioid crisis prepared us for that endurance piece, because we've been enduring that for years now. And then the COVID was just a whole nother animal, but we're used to those long stamina, going to a lot of those similar calls. So the introduction here is, us as public safety personnel, police, firefighters, paramedics, correction, borders, services, we're required to perform our duties, during this escalating public health orders. We're emergency services, so we're essential. We're always operating in those kind of climates. But the concern of the exposure through that client contact is obviously heightened. We're going to talk about this. There was a supply issue, definitely. The hospitals were gathering a lot of PPE, obviously, because they needed the most, but we are, frontline first responders, and we needed to be protected well. So that was going to add some additional stress. Definitely inadequate staffing when it came to the paramedics, for sure. People booking out sick, long working hours, all those factors for sure. Isolation from family and friends, that isolation alone, we all know, is an issue. But when you're starting to, you're working at an emergency pandemic level, and you're having to isolate, or you're fearful of infecting your family and friends, that adds another layer to this. So it is managing those family responsibilities, especially when the schools shut down. So those are another layer of stress. And then, of course, there is some discrimination towards health personnel, and worried about us coming into community centers or into their homes, spreading the virus. And of course, there is substantial risk of us contacting the virus in the work environment. So those are some of the things that we're going to talk about.
Thanks. So I'll talk a little bit about some of the data we collected. The idea behind this data collection was to really document and understand the burden placed on public safety professionals during the pandemic, and make a case for what sort of supports would be needed in the different phases, and how we might respond to that. So we did a survey in phase, and we have data from everybody pre-pandemic, and that's courtesy of Dr. Carlton and folks at the University of Regina. So we stripped BC data out of their large study and the pieces that we were going to compare to, and that's our baseline. We have all of our respondents in phase 1, and then we have one other phase for every respondent. So some were in phase 2, some in phase 3, some in phase 4. So we have covered all of the different phases with data collection in our group. And we collected depression, anxiety, PTSD, social anxiety, and we ended up having 2 open-ended questions. One that asked about how their work changed and one that asked about how their home life had changed. And I'm not going to bore you with all of the statistics, but we looked at pre-post. So we looked at pre-COVID and post-COVID scores. And then we also looked at whether the response escalated across phases of the pandemic response. We ended up with 48 public safety communicators, 123 firefighters, and 245 paramedics respond to an open call for responses. They were all typically mid-career, and we really saw most of the difference in depression, and there was some change in social anxiety. And I'm going to show you the data versus that. In these graphs, the before COVID is going to be this blue color. And then after COVID, in any of the phases that they responded in, this would be the sort of the red bar. So when we look at depression, we see that in every category, depression had gone up post COVID. So once COVID in phase 1, 2, 3, and 4. The other thing that's interesting in this data is that it escalated across phases. And you're going to see this in every one of my slides. And so here you're introduced to a potential pandemic. We know that we're getting cases in British Columbia. They're starting to go up. We hear a lot about it on the news, and China and Italy and some of the countries with early impact. We haven't really saw the impact in Canada yet. And so we're just starting to get some restrictions in British Columbia. And phase 2, the restrictions got crowd size, like whether you could eat out, those types of things. We started to get a much more regimented control. And in here, we started to see escalated cases. We started to see BC data. We started to see that ICUs were starting to get full. There was some heightened arousal around that. At some point, you thought we were going to recover and we didn't, and there's this sort of complacency around it. And so in every one of these, if you look at phase 3, it's our smallest N too, so that's a little bit of an issue. But there is this dip in all of our data. And then once we closed everything down, we had the heightened response, and it was almost the largest response for almost every one of our categories. So again, this is just showing you across the phases that there was more depression due to phase 4 than there was in phase 1. Social anxiety, sort of the same. The only significant data in social anxiety was in paramedics, but you saw the firefighter population also had an increase in social anxiety. That went up and then sort of flattened in our data. PTSD, we never really hypothesized to change because PTSD is a downstream impact. You have the events, you're living the events, you're responding to the events. And once you have distance from the event and you reflect on the events and how that impacted you and how that impacted your relationship with your family and your friends and how that impacted you at work, we wouldn't expect PTSD to be during the event, and that held true in this data. There's no significant difference in the PTSD. And when we looked at across phases, a few things. Paramedics had a more dramatic increase in scores related to depression. This we hypothesized. If you look at our populations, we have somebody that responds and transports, somebody that responds but doesn't transport, and somebody that doesn't go on site, right? So we had 3 categories of responders, and we expected the ones that had to transport and have that very prolonged contact with somebody to probably have the greatest impact, and that was the case. And so compared to firefighters, paramedics had a more dramatic increase in scores related to depression. Communicators and paramedics had increased scores related to general anxiety as compared to the firefighters. And we had greater increase in social anxiety across the public safety communicators and paramedics as well. And there's a lot of data there. I really don't want to just spend time on the data though, because we also have some qualitative results. And I get Steve to talk to you about this.
Yeah, I mean, those are pretty significant stats that you showed. And I did, talking about that PTSD not really changing, you're in the war still, and so you're not really going to see that change. But it's interesting. We talk about how that has changed us, and there's some paramedic quotes there that kind of basically sum up that losing purpose. It's almost a moral injury that was caused by this pandemic, and we already were dealing with burnout and compassion fatigue. Dealing with low numbers of, they needed more manpower for sure on their job, and they're already behind the 8 ball. And then basically what happens, with our job in the fire world is we stopped going to those calls, and because we were trying to mitigate our risk, we couldn't afford to take out a crew or a shift of firefighters and not be able to do the other stuff that we do, car accidents, fires, and everything. So the medical calls, we basically turned the tap off. And that put huge pressure on the paramedics. And because they could transport, they were, and then it's just communicating with patients. Like that transformed how we talk to our patients. You'd go in and just by your facial expression, you were able to provide patient comfort, make them calm down. And now you're wearing basically a hazmat suit into these calls, which that transformed patient care for us. How do you communicate to someone? You can't give them a reassuring smile, like they're just looking at your eyes, and that heightens everything. And so you come in and they're already stressed because they have COVID symptoms, and then you add that other layer where you're treating them like they're contaminated. Well, they were contaminated, but you are treating them with this hypersensitive PPE, face masks, respirators, gloves, and a Tyvek suit. And my God, that just heightens that stress of everybody all around. And you wish you could have a badge with your face on it so they can at least see your face when you're communicating with them. So it definitely has transformed how we've done our job, and there's major personal costs to that. Your home life is affected. Your kid gets pulled out of school because of a COVID exposure, so now you're worried about bringing that to your colleagues. And I don't know, as a firefighters, we started driving around with masks in the truck. And it took us a while to really wrap our brains around that. Like, wow, we've been working with each other for a 10-hour shift, 14-hour shift, to some departments like Vancouver, 24 hours. And now you're wearing masks in the fire hall, around the kitchen table. Like, it creates this isolation and distance from people, and it really personalizes that protective factor that we have in the public safety personnel world. Is we're family. That's a secondary family. And now you're adding this awkwardness to those interactions where you come back from an emergency call and you downregulate and you normalize and you hash it out. And now you can't even do that because you're having to be 6 feet apart. Cooking completely transforms. Like, a big part of the fire services, we cook together like a family, we eat together, and that was transforming. Tables were separated. You're eating in different rooms, and you're not even eating together. And I can't even imagine the paramedics. I run into crews and they're eating on the run. They don't have any breaks, and they're going balls to the wall. It's like nonstop. And so that just add that pressure to what was already existing, and it's like a pressure cooker, right? It's got to be a relief valve. So massive personal cost, and we're going to see the results of this later on, I bet, once the dust settles. So.
Thanks. One of the stories that we didn't put up here was a really compelling one too, about a paramedic who picked up a COVID patient, transported them to hospital, spent time with them until they were admitted into ICU. Their very next call was a mother with a 6-month-old infant who needed treatment, and they put them in the back of the ambulance to transport them. And the stress around whether they, got the ambulance ready and it was safe and that this child was going to be okay. And so there's layers and layers and layers of added stress from the COVID response in these groups.
Mm-hmm.
It's not easy to have a discussion in this. There's very, very little data. There's lots of opinion pieces and looking at previous pandemics and what might occur. One of the early studies was in nursing, and they looked at moderate to severe anxiety and moderate to severe depression, and they both went up during COVID, the initial COVID response. And this was the first data that had pre and post measures that I could find in British Columbia. So the healthcare workers were studied, and they tried to respond and say, okay, how do we protect healthcare workers as frontline workers, much like our PSP? And when you looked at it, the data from other responses, not necessarily the COVID response, a lot of this would be from avian flu and SARS, those types of responses. And PSP expressed concern and fear of contracting and spreading the virus to others, particularly their families. And this was a major contributor to the distress of frontline healthcare workers. But again, this was a review paper, and it's reviewing data that wasn't COVID specific in particular. So just a rider on that. One that was during COVID was looking at paramedics responding. And this is trying to support that the job has changed. And what they found was that there was an increased rate of non-responses and increased rate of non-transports. And the non-transports are, is the system full? Are you putting the patient at risk by moving them to a hospital where you're treating COVID patients? What can you do in place? And so there became a greater increase in place of care. So you're providing care in their place rather than transporting, which really is a shift in how they worked and how they did their job. The personal costs, again, through some reviews of previous data, they predicted that the COVID-19 pandemic would increase the mental health problems of the global population. This wasn't specific to PSP, but just trying to say that we should be prepared that as you quarantine, you isolate, and you do a response to the pandemic, that you're going to have an increase in mental health problems in the general population, which is probably exaggerated in PSP. They didn't say that, but I would. And so finally, there was one study of European police officers during COVID that looked at stress, demands, and coping resources. Interesting because, again, it was one of the first concrete pieces of data during COVID that you're going to see in some of these populations. And in theirs, risk of infection and deficient communication were huge stressors to the people on the front line. And I think that's a pretty common response that I hear. So, Steve, do you want to talk about the so what?
Yeah, we talked about this earlier. So what? I think the COVID piece, we were already in a mental health crisis prior to this. I mean, we take us back to 2015 when we had a string of suicides in Surrey Fire. There was police and paramedics dying by suicide. And we were already in a crisis, in a mental health crisis, as far as I'm concerned. We were looking for resources. WorkSafe BC combined with the BC first responders from all over and from labor and management to find out what is the issue, what are the gaps, what can we do to help support public safety personnel in BC. And we struck committees and we've product recommendations. And what the COVID pandemic did was shine another spotlight on that. And I said to Greg earlier, it was like the straw that broke the camel's back. We were already in crisis. We were already stretched thin. We were working on trying to improve benefits and education and resiliency training and resources for our folks and our families. And this COVID thing hits us and it took us out at the knees. And I think that's the so what part is. It's great to have this research. It just validates that we are hurting, that we need resources, that leadership needs to wake up and acknowledge that there's things that we need to do to support our folks. And I think that's that's what I got from that. And I'm really glad that this just validates what we need to do more. And you've got the next slide up here is exactly, we need to work on these three things. Do you want to take it from there?
Sure. When we looked at some of the things that might come up, it would be training. And at the beginning of the response, specialized preparedness training, the PPE, the use of the PPE, how you would treat someone. Was it different than other responses? How would you respond medically? All of these things were sort of unknown, and they changed daily. Nobody really knew, and then everybody had a different opinion. So the preparedness and the communication of that was so important. So how do you make sure that people have the up-to-date information that they needed to do their work at that particular time? And then the training also around decision-making aids, so that they felt supported in their decisions. And an example would be, why were there so many non-transports in the paramedic services? That was in Australia, I think. So they had helped them make decisions on who they transport and not, so that it wasn't just up to the paramedic. They were being trained and given aids on those types of decisions, and when you'd be putting somebody at risk by transporting them. So the training and the communication at the beginning of this was vital to make sure that people were keeping up to date on the information that was coming out, and that we were supporting our people in making decisions and supporting those decisions when they were made. And that really took stretched leadership. They had to be visible, and they had to keep up to the current data. And that was really problematic, because that changed daily. There were changing public health orders. There were changing ways of what was, best practice daily. It really was shifting, and best practice may include some protective equipment that you couldn't get because of demand. And so these all put a lot of stress into the system that needed to be acknowledged. Steve, do you want to chat a little bit about?
Yeah, and I mean, this doesn't just apply to the COVID-19 pandemic. I mean, principles for good leadership, during crisis, we're in the business of crisis, and this is just a rather long one. But I mean, this is our bread and butter stuff, but you nailed it, is that communication, up-to-date information. It's collaborating with unions when they're in place to formulate the plan of how to communicate to everybody, off-duty folk, people that are on duty, and keeping them up to date. Like you said, stuff changes so rapidly that, there was many public safety personnel or employers that struck committees, joint committees to handle the PPE issues. We were getting I was on a COVID task force committee where we're constant updates on PPE, messaging out the new practices, the hygiene stuff, cleaning, daily cleaning, what chemicals to use, like all of those things. So that was really, really critical. That communication piece, you can't underscore that. But that goes for everything. That provision of the continuous staff support, it's offering, I know our city did really well in Coquitlam. They were offering clinical services, online CBT. Like it's not only supporting your staff through PPE and all those things, but it's like those mental health pieces, supporting the family, being empathetic that, you might have a crisis at home, a COVID crisis at home, and then you got to respond to work and be on the front lines of that crisis. So definitely we're finding, that the highlight piece there is the need for services will increase. I think they're going to increase even more post-COVID. Right now we're in the war, and everyone is just, you're in survival mode. No one's thriving. We're all surviving, and we're, how do you support those people in place at work so they stay at work healthy and feel supported? So again, back to leadership though, of course, it's compassion. You're being compassionate. You're being understanding. Those long working hours, you're going to have to manage your staff and appreciate them, right? It's getting out there and saying, I know management is a stressful place. You're managing resources and manpower, by getting out there and saying, hey, you're doing a great job under the circumstances. Like an attaboy goes a long way, or an attagirl. And so I think that's really, really important. And then of course, the very last point I think is really critical. Personal circumstances, they are changing rapidly. And on top of this COVID piece, there's life crises happening, life challenges. There's people, parents are dying in care homes, and maybe they're out of province, and then just general life stuff that's stacking on top of that. So definitely, as a leader, is a very dynamic piece. I don't envy them in those positions at all.
So one of the things that we wanted to highlight, I guess, is the role of leaders and the role of leaders at every level of the organization. We're not talking about just at the top of the organization. As a leader of a group of people, as a pair, working in a pair, I mean, you need to recognize and address the uncharacteristic behavior and performance that might pop up. You're not diagnosing, right? That's not your job. Your job is to recognize when somebody might be in trouble and trying to reach out to them and understand that. And the typical signs of people struggling would include increased conflict, unprofessional behavior, either inside your group or external to your group, maybe to the client base that you have. Whether they're late or taking long breaks or absences, either excused or unexcused absence from work. They may make more errors at work. The quality of their work may go down. They try to avoid things. They lack participation. They may forget things, and there may be some sort of change in hygiene. So this is just to reinforce that recognizing and reaching out is everybody's responsibility. It's just not the person at the top of the food chain. Leaders need to support this. They need to give people the training and the ability to do this. But it has to be everybody in an organization that is watching out for their colleagues during these more heightened responses. Anything to add to that?
Yeah, for sure. I think I love that we're all leaders, whether you're a leader of a crew, a two-person team, or you're a peer support person or a chaplain, or part of the critical incident stress management team. I think it's an all hands on deck piece. And I think those check-ins are really critical. I was doing that prior to COVID, but I would sit down at the start of my day shift and I would check in with my crew. What's going on at home? What are your expectations for the shift coming up? And I think those conversations are really critical to say, hey, what stressors are you bringing to work? What can we do to help you? Are you having trouble sleeping? Talk to them about the resources we have to extended health benefits. And then, for me, it's about observing those personal struggles. It was palpable when we were at the height of this. You could sense the tension in the room, and so it was really important for me to not single out people, but connect people to, hey, this is a peer supporter. I want you to keep an eye on this guy. I want you to reach out to him. I want you to go for coffee with him, and I want to do some follow up. So if this is an ongoing training, whether it's a pandemic or not, we need to do this all of the time, and we need to take the pulse of how we're doing and provide those resources and that empathy and that emotionally intelligent leadership that is required. And that, you're right, it's at all levels. So it's a continuum for sure, right?
So again, no, using this idea that leaders are distributed across an organization and they're not at the top of the food chain. We as people that need to work through the pandemic need to recognize that COVID's going to have an impact on your work. Your work has changed. We've shown that your ability to respond at home and some of the home stresses have changed, and how you might deal with children that are off school and those types of things. So things at home and work have both changed, and that we need to be able to help others respond. We can't rely on one person to be the only person that reaches out and can recognize individuals in need and know how to create a conversation and a safe place for them to talk. And part of that is displaying empathy, understanding and sharing feelings, recognizing that their feelings are real and that they're probably not alone in what they're going through, would be something that they could do. Within the organization, though, we really need to make sure that, now I'll talk to the top, that they are really strong advocates for training, that they advocate for recovery time, and that they advocate for increased services. And this is really essential, because in a lot of these occupations, what we heard was that as people were exposed to COVID and they had to isolate, the number of people that they had in rotation went down, which meant that, you know, your overtime went up, you worked long shifts, you were needed as the healthy crews, and that put a lot of stress on the system as well. And so making sure that we could find time to recover and get them time to seek you know, help when required was really important. So just to end this, you know, we talked about the organization and the individual a lot today. When you're trying to look at providing a psychologically safe place to work, there are multiple levels where that has to be. Part of that is at the individual level. How do individuals interact? You know, can they recognize their own stress? Do they have a suite of coping skills in order to reduce their stress? And so there is that individual component to that. But the organizational culture and whether it's viewed as being supportive and providing the assistance that's required to allow them to work in a safe way, giving them the equipment they need, giving them the supports that they need to make sure that they can work in a safe environment. And looking at the organization and the interactions and where those sticking points are when people are on shift and going through long hours, extended hours, that type of thing, addressing behaviors such as bullying early. You know, that may be the beginning of a mental health issue where they become more frustrated and disconnected. So how the organization is responding is really important to that. And then the piece that we often forget is that the family is where they spend a lot of time and where they get the social support from. And for the families to understand what the PSP are going through and how COVID has shifted what some of the work responsibilities are, and that uncertainty of exposures at work versus at home, and getting them to understand and learn how to be supportive of the public safety professional is really an important piece to this. And I think we'll hear more about this. I mean, the military's been doing this for many years, and I think more and more we recognize that the family is a fundamental pillar in the person's well-being, that it's not just the work environment that can create stress, but the things that are happening at home and how they interact and the expectations of a spouse of a PSP member on the PSP member, you know, may be unrealistic at times because of the stress that they've encountered at work. So we really need to pay attention to all the whole ecosystem that supports the individual and their work when we look at responding. So that's sort of where we wanted to get to. Steve, any other comments before we open it up?
No, I think the three pillars of resilience that you talked about, we have to, as public safety personnel, we have to take responsibility and personal accountability for our own mental health and physical health. And you said it is a holistic piece, whether it's physical, spiritual, mental. We need to be in the driver's seat for that. There are resources. You mentioned one of the family piece is absolutely critical. I think Dr. Carlton's research really highlighted that family support is critical as a protective factor to weather those long accumulative stress that you get in our occupation. And the education piece, it's educating family, doing family nights, it's providing resilient minds training, sleep education training. It's critical. We're finding that because of this pandemic and the long working hours, and even prior to that, when you have accumulative stress or operational stress injuries, sleep is the number one thing that is affected. This is the number one thing I hear. And if you can't get that sorted, you're never going to treat anything else. You're not going to treat any other mental health challenge without sleep in order. And I think, I mean, there's a real highlight on that. Dr. Glenn Landry's done some work with us on that, and Dr. Maya Love, we had a sleep session on that. And I know Dr. Glenn Landry's done a bunch of work with the paramedics as well, because we just think that one needs to be underlined twice, is sleep education and circadian rhythm. It's interrupted, and we need to get that. We need to capture that, especially with us shift workers. And the employee assistance program, I'm just going to say that's a bargaining thing for many contracts and employer groups. Employee assistance programs are a stopgap. They are short-term. This is not a short-term issue. It's what we've been finding. This is not your little bit of conflict at work. We're talking of years of probably unprocessed trauma and maybe a psychological injury, and you need proper resources to deal with that. You need psychologists, you need registered clinical counselors on a long-term 10 to 20 sessions to deal with a lot of this stuff. If you can get people into counseling with occupationally aware clinicians, this is someone that understands our world, can talk to us and relate to us. And I think those are the things that I would highlight in that little last slide there.
Perfect. Thank you. So we'll turn it back over to you, Emily.
All right. So to everyone in the audience, you can feel free to submit your questions to the questions box or raise your hand to ask a question. I am going to start with one question for you, Greg. They have asked, because that PTSD line was flat, do you expect once the pandemic is completed, if it ever is, if that line's going to just skyrocket? That people with PTSD, once the war is over as it is, will it just skyrocket?
That would have been the hypothesis for sure, that it would remain flat until there's some relief and some distance from the major stressors of COVID. As you say, COVID isn't going to go away, but our pandemic response and that the lockdowns and some of this, as that shifts and we distance ourselves from those responses and the trauma related to some of that, that is when we would expect PTSD to go up. And yes, I do think it will be significantly higher once we start to process what happened to us at work, in our family, and individually once the pandemic has settled.
Okay. Next one's for Steve. How have you seen the response change from wave 1 to, I think we're in wave 4 now? How have you seen that response change for people in your organization?
In my organization, it's changed drastically. We went from, and it's interesting, it kind of follows the data that Dr. Anderson presented, is that we were almost complacent in the beginning and we didn't think it was going to affect us. And our response was, we were wearing PPE, but we weren't as hyper vigilant. And then when phase 2 hit, we're like, oh, this is real. And stuff started to absolutely change. It changed the feel at the station. It changed the way we responded to calls. You could feel the tension with our folks, bringing that home to their families. The current concern and worry was palpable. And then there was a bit of a pause, like, okay, there's a bit of a lull there where we let our guard down. And then all of a sudden we got smacked in the face again and everything came back raging. And so we were, as a peer support team on our job, we're really checking in with everybody, and we're making sure to be, hyper vigilant on that side. We were really looking for signs and symptoms, as we described earlier, who was having the hardest time. In fact, when we had, and this is for many organizations, is when we actually had members get COVID, which was few and far between, but when they did, there was some interesting stigma attached to that. There's already stigma attached to a psychological injury, but when you get COVID as well, you're almost ostracized or you're vilified, or how could that happen to you? And people there was some shame component to that as well. They felt terrible that they got infected and could have infected others. So it was definitely evolved as the pandemic went along, but I hope that answers the question.
I've got one last question, but just a reminder, you can go ahead and submit your question to the question box if your question hasn't been answered. Last one, I will direct this to you, Greg, is what do you think the key thing that an organization can do in order to stop that kind of buildup of mental health issues once the pandemic is over?
Muted. This answer will come. This is why we need leaders to understand that we need to put the resources in place now. We need to find the resources. We need to find people that understand the occupations. We need to find the people that that know enough about the stresses and the strains of the occupation that they can actually have real conversations with the PSP when they go forward. So making sure that there's a suite of people that people can see moving forward, making sure that they recognize people that are struggling early. All of those things can help. But if you have no resources in place, you can recognize somebody early and just leave them flounder. And so recognizing that this is probably coming, we've watched it escalate all the way through the pandemic. We know that there's probably going to be a wave of increased Ptsd post. And one of the things that we can do now is make sure that we have good support networks in place for when it happens, and that we can get them access early, that they're not waiting for months and months for treatment, and having the PTSD fully be involved and the moral injury to increase, and them to think about it and dwell on it and have it become a major part of what they do daily in their thought patterns. So if we can get that early response, and I think we will definitely be helping them reduce that wave that would come.
If I don't mind, my add personally is that, you know, we've always talked about upstream care, and I think it's so critical that you don't wait until the pandemic's over. Obviously, you need to look already at your gaps. You need to do a gap analysis. The BC First Responder Mental Health Committee, I think you added a link there for everybody, but there's a great leadership section where there's 26 recommended practices you could do right now. And I think there's a gap analysis on there as well. You need to look at your organization, what are their gaps, what education you need to do, and follow those recommended practices to basically provide some protective factors for your organization and for your people. I think education is key, and you need to have that whole holistic approach to that in order to prepare yourself. And that's not just for this COVID pandemic ending. Our jobs don't end.
Correct.
The emergencies aren't going to end. There's going to be another wave of something happening, and the opioid crisis is still going on. I'm still going to overdose calls on a regular basis. We are still in the trenches, and we're going to remain in the trenches after this. So we have to acknowledge that we have to have these pillars of resilience built in right now if they haven't been already implemented.
So I've got another question here. What structural resources as being a pillar of resilience? I'm struck that you can't yoga, eat, or sleep our way out of a pandemic where our healthcare and public safety infrastructure is under-resourced and overextended. Can you comment on opportunities for larger structural changes in improving health and well-being among personnel? I'll let you go with that, Greg, and then I will turn it over to Steve.
I was going to pass that to Steve.
Ooh, it's a hot potato.
I mean, it's very difficult as a scientist to say, this is what an organization should be doing. I mean, we can make recommendations, we can help consult, we can try and help make good decisions. But in the end, the organization, the employer, the unions have to agree that there is going to be a structured response. And, there's an age-old one around, do you get personal time to be fit and well for your employment? Firefighters may have more time, structured time in their day that they can do their wellness activities, whereas paramedics probably don't. So does that put them at increased risk? Well, that becomes a bargaining issue, which is why I think it's a hot potato. But do I think it's a good idea? I mean, if we need to try and come up with programming, support networks, support systems, whether that's allowing them to have time to meditate or do their wellness practices, that should become part of working in these professions at some point. But it is definitely going to take some discussions with the employers and the employees. Do you want to add?
Yeah, I personally think I can sleep and eat my way out of this pandemic. So, but in all seriousness, it is a concerted effort, and I wholeheartedly agree that it's a collaborative, coordinated effort on the labor and the management side. And then you have to have family support as well. So it's all of those components. And at an organizational level, if you want to look at the structure of an organization, mental health and resilience need to be intertwined at every level of what you're doing in your organization. And that's responding to incidents, after an incident, how are you supporting people in crisis, and post-family crisis, as well as critical incident crisis. Having the proper resources at a structural level, providing $5,000 in psychological support, like Starbucks does for their employees. Like that, start there. That's a great starting point, right? Because your return on investment of investing in your biggest asset, which is your personnel, it's going to pay you back in spades. And I think there's a lot of evidence and research to prove that you spend a dollar, you're going to save $3 to, I think it's all the way up to $8. And maybe I'm exaggerating, but I'm going to say, never mind, you're
$27 in
exactly. So
dollars spent.
And
range.
Yeah, and it's not only you're saving money, it's the right thing to do. You're supporting a huge asset on your organization. You're not going to run an ambulance or a fire truck or a police cruiser without personnel. And so you need to focus on your biggest asset, which is your people. And that's where you pour all of your energy into, as far as I'm concerned.
Right. I think that speaks directly to a comment that we just got, was that being frustrated that the EAP contracts all have a 3 to 4 session cap. Right, yeah. And with the recent election and other elections in the past, that mental health has been a big priority, but that cap still exists. So obviously that's something that is individual to organizations, individual to provinces. I wish we could fix that here at CIPSRT, but we don't have that power. All we can do is do the research to recommend things to government.
And advocate, be advocates for the groups that we work with.
Yeah. And you can think that's the key piece here is your research at CIPSRT and what Greg is doing highlights the need. There is a need for resources here, and occupationally aware resources. I keep harping that. It's not just your average psychologist. It's someone that's trauma informed, understands their culture, understands the inner workings of how to return someone to work or keep them at work, what connections are required. That is the critical piece here. And we are a stoic work culture, and you have years and years of accumulated trauma that's not been dealt with. You throw a pandemic on top of that and a family crisis. No wonder we're taking knees at a record rate right now. So, and look out, there's another wave coming after this one too. So as we break down that stigma, people are going to put their hands up and they're going to go, I need help. And where are the resources?
Right. And I just wanted to let everybody know that in the chat, I did put, there's also a SASC First Responders Mental Health website available. Also put that in the chat. My thought would be anybody who's not in either BC or Saskatchewan, maybe just do a quick search. Might be that your province has something very similar. I think that's something that all the provinces have been working on, is having something like this resource. So take a look, but if not, look at those websites. There might be something you can use from them, like Steve was talking about with the leadership side. We don't have any more questions, so I am going to go ahead and wrap up the session for today. I just want to thank both Greg and Steve for being with us, and everybody in the audience for this great session. There will be a quick survey at the end of the town hall. We hope you'll take a moment to complete it. Let us know how we're doing. Let us know what you want to hear about. We will be hosting our next town hall on November 18th, and it is titled Exploring Job-Related Burnout and What It Means for Public Safety Personnel. And that's going to be with Dr. Donald McCleary. A link for the session will be in your follow-up email with today's recording. So again, thank you all for attending. Thank you to our speakers, and everyone, stay safe. Take care. If you're in Saskatchewan, be prepared for slippery roads.
Thanks, everyone.
Have a
Take care.
great day.